This is a quiz. Alcohol, even in moderation, should be avoided by prostate cancer patients most of the time. Yes? No? True? False? The false wins. Moderation is the key. Next. Sexual relations by raising testosterone are potentially harmful and could make some prostate cancers grow, especially metastatic disease. True? You just said that was false. You're right. No effect. Next. Men with active prostate cancer need to use condoms, or their sex partner could be exposed to potentially harmful cancer cells, which might damage their partner's immune system or possibly even cause some type of cancer in the partner. Of course. These are just some old wife stories or tales. So, now, can I ask you something? What kind of best friend has your testicles removed? Remember, the doctors will say, we can help you. All we have to do is orchiectomy. So I don't think that's the best friend. And of course, if you have testicles removed, you can't be on intermittent hormone blockade unless you use testosterone replacement therapy. Okay. Now, our primary focus tonight is management of high-risk, metastatic, and/or recurrent prostate cancer, which would also include management of metastatic castrate-resistant prostate cancer patients. But first, we have to define what is low-risk prostate cancer, intermediate or high. So low risk has to have all three: PSA less than 10, Gleason score less than or equal to 6, and digital rectal exam, not scan, just a rectal exam, has to have either a normal exam or a nodule involving less than half of the diameter of one side of the prostate. Intermediate risk, once again, all three: PSA 10 to 20, Gleason score less than or equal to 3 plus 4 total 7, not 4 plus 3 total 7. You know, there's been a change in the Gleason score. In the past, by the way, Donald Gleason just died 4 years ago, but when he came up with his scoring system, when you look under the microscope of prostate cancer, the most predominant pattern is the first number in a Gleason score. So in this case, the most predominant pattern was 3. They go from 1 to 5. 1 is the least malignant, 5 is the most malignant, most aggressive. And the second number in a Gleason score is the second most predominant pattern. So in this case, the most predominant was a 3, second most predominant was a 4. That was 7. But it turns out that a Gleason 3 plus 4 behaves more like a Gleason 6. A Gleason 4 plus 3 behaves more like a Gleason 8. And there's one new major change in Gleason scoring. What is done now is the first number is still the most predominant pattern. The second number is no longer the most predominant pattern. It's the highest Gleason score. So if you have somebody who is a predominant 3, the next most predominant 4, and there's 3, 4, 5% of 5, that person's Gleason score is 3 plus 5 now. And that was agreed upon at an international conference of pathologists in, I think, 2005. And the last part of intermediate risk, digital rectal exam, revealing that there's prostate cancer involving one or both lobes of the prostate, but not extension through the capsule of the prostate. High risk is any single one, PSA over 20, Gleason score greater than or equal to 4 plus 3, rectal exam, extension through the prostate, and this is with seminal vesicle involvement. Lymph node status is taken into consideration, NX means regional lymph nodes were not assessed. Regional refers to pelvic lymph nodes. N0 means that the lymph nodes were examined and there's no metastatic disease. N1, there are metastasis in a regional lymph node or lymph nodes. Okay? Then in looking at distant metastases, MX cannot be assessed. Maybe you didn't do scans. M0, no distant mets. M1, there are distant mets. And this is further subdivided. M1A, non-regional lymph nodes, that's distant, whereas if it's regional lymph nodes, it's N1, not distant mets. M1B is bone or bony involvement, many bones. And M1C would be involvement of other sites in the body. Now, the low, intermediate, and high risk that I described is generally the D'Amico classification. But there are many other high-risk definitions. And these are negative prognostic factors that some consider make a person high risk. Involvement of 50% or more, prostate cancer involvement, 50% or more of any single biopsy core. The reason for that is when you stick the needle in, your typical length of the specimen may be 1.7 centimeters, 17 millimeters. And if there's involvement, let's say, of 80% of the core, that suggests generalized involvement of the prostate rather than just a little nib of it. Okay? Involvement by prostate cancer cells in half of the biopsy cores that you obtain. And as you know, in the past, urologists or radiologists took 6 biopsy specimens called sextant, like the points on a sextant. But nowadays, if you get less than 10 to 14 biopsy cores, you probably were not served well. Perineural invasion, a lot of people believe, is a negative prognostic factor. The nerve sheaths, nerves are like tubes, and they run from inside the prostate through the capsule to the outside. And prostate cancer cells can just track along those nerve fibers, and they get like a shortcut to get out of the prostate. Hence the belief that it is a negative prognostic factor. By itself, I don't believe I call it high risk. You just worry a little more. And if somebody is thinking about going on active surveillance, if 3 or more of the specimens you biopsied showed prostate cancer, that usually will take them off active surveillance, but tell them that they have progressed and it's recommended by their doctor that they now need some type of therapy. And testosterone, if you have prostate cancer and your neighbor has prostate cancer, and a normal testosterone level, let's say, is 300 to 800, would your prognosis be better with a low testosterone, say 325, or a high testosterone, say 825? Which would you rather have? Low, if you have prostate cancer, no evidence of metastasis. Low, high. Low. All right. And if you have metastatic disease, low or high? Okay. Turns out if you take groups of men with metastatic disease, bone scan abnormalities, the men with the highest testosterone will live at usually twice as long as men with lower testosterone. The reason for it is, what is the major treatment for metastatic prostate cancer? Hormone blockade, right? And in hormone blockade, you're lowering your testosterone level. Now, if you start with a low testosterone and it's metastatic, it means the prostate cancer cells have figured out how to survive and grow in a low testosterone environment. They're already beginning to be hormone resistant, if you will. They're not, by definition, hormone resistant yet, but if they have a real high testosterone, think of how you're going to whack those cancer cells when you take it away. Now, management of low risk and most intermediate risk patients. This is our approach. 13 months of triple hormone blockade followed by Proscar and or Avodart maintenance therapy. Triple hormone blockade is a treatment that I created and pioneered, and in fact have a registered trademark for it. So anyone that says they invented triple hormone blockade or triple androgen blockade or finasteride maintenance therapy, they're lying. I published the first papers on it, and the patent office would not give me a trademark registration if I wasn't able to prove it. And I don't want to spend much time on this because tonight is high-risk night, and but those of you who are interested in this because you have low-risk disease, you can call my office. You can get a copy of a lecture that I gave on management of low-risk disease. We only charge $5 for shipping, and the DVD itself is free. And if you happen to stop in the office, you can get it for free, period. Okay? And at the end of the 13 months of therapy, consider high-dose testosterone if desired, and we'll get to that. Now, in July 12, 2012, the New England Journal of Medicine reported an article of the PIVOT study. PIVOT study means prostate intervention versus observation therapy. The prostate intervention, radical prostatectomy. Men were prospectively randomized. The doctor couldn't tell them which group they were in, patient couldn't request which group. And at the end of 12 years of follow-up, what did that study show? Who had the better survival, radical prostatectomy or observation? These are all men with primarily PSA-identified prostate cancer. In other words, they didn't have an abnormal rectal, they just had an elevated PSA. Well, radical prostatectomy did not significantly reduce all-cause mortality or prostate cancer mortality compared to observation through at least 12 years of follow-up. The study suggested that high-risk patients might benefit, but for low-risk patients that I defined in prior slides, survival was better in the no treatment group compared to radical prostatectomy. Survival was better in the no treatment group, overall and prostate cancer specific. Now, this study was conducted at the National Cancer Institute. And if you think about it, went on for 12 years, started I think in, I don't know, 94, 98. And imagine you go into the National Cancer Institute, you've got prostate cancer, and you say, I want to enter the protocol where you're trying to find out the best treatment. What are the two treatment arms? Well, one arm is radical prostatectomy, okay? Well, what's the other arm? Well, we'll see you again in 6 months. Yeah, but what about my medicine? No, we're just going to observe you. Well, wait a minute. How can that be? Everyone knows if you have cancer, you need to get it out of your body or you're going to die from it. Surely there had to be studies done in the past that showed that, right? Because if not, how are urologists and radiation therapists doing all of this treatment on men? Well, come to think of it, there was a study done by David Byar, B-Y-A-R. And in that study, men were randomized between a pill plus radical prostatectomy. The other group just got the pill. There was a 23-year follow-up. And the results of the study showed no difference in survival between radical and pill versus pill only. And the name of that pill was placebo. The group that did the best was the placebo group. The group that did just as well as them were the men who refused surgery. So this is not the first study that showed this. Okay? Now, how could it be that prostate cancer survival doesn't improve with surgery? One way is, what if prostate cancer cells already escape the prostate by the time you find it? So at a 2005 American Association of Cancer Research meeting, there was a study reported, 500 patients. They were on the table, surgical OR, to have radical prostatectomy. Before the radical prostatectomy began, a bone marrow sample was obtained, where you make blood. And the majority of men undergoing radical prostatectomy for what appeared to be clinically localized prostate cancer were found to have tumor cells in their bone marrow, prostate cancer cells. The findings support the hypothesis that tumor cell dissemination, spread of tumor, is an early event and increases with the aggressiveness of the tumor, like, for example, higher Gleason score, higher PSA. Okay? Detection of tumor cells related increasing stage, Gleason score, PSA, and tumor volume. I would predict, this is not me, this is Vesela, I would predict that basically all patients at the time of diagnosis already have disseminated tumor cells in their bone marrow. Now, why don't all men die then? Because you can have cancer cells, but they may remain dormant for long periods of time. Now, in 1993, I stated my opinions, and I published it, and these papers are available for free at our website, Compassionate Oncology. For the past 20 plus years, I've believed that and preached the best local therapy is systemic therapy. So what does that mean? Well, I speculated that 2/3 to 3/4 of men presenting with what looked like clinically localized prostate cancer already had systemic disease. And that bone marrow study showed I was right. Now, what local therapy versus systemic therapy? Local therapy includes things that you do locally to the prostate, such as radical prostatectomy, radiation therapy, cryotherapy, seeds, brachytherapy, proton therapy, treatments that are directed only at the prostate and maybe some of the adjacent regional lymph nodes. Systemic therapy means treating cancer with medicines. In fact, the word chemotherapy means medicine treatments. The first time that word was used, it was used in the therapy of syphilis by arsenic. So chemotherapy, we all what we picture in our minds, chemotherapy. Remember, the first time it was used was using arsenic to kill syphilis. All right, systemic medicines such as triple hormone blockade without my registered trademark, and or chemotherapy and or anti-angiogenic cocktail can kill prostate cancer cells anywhere in the body, like lymph nodes, bones, and even so-called visceral organs like liver, lungs, etc. Autopsy studies were done on men who died of street violence in Detroit, because when a guy is diagnosed with prostate cancer and the urologist says, you have early prostate cancer, that's an oxymoron. Because men who died of street violence, 27% of men in their 30s were found to have invasive prostate cancer, not precancer, not intracellular, intraductal. 34% of men in their 40s had prostate cancer. And for African Americans, prostate cancer was multifocal in over half. That means new separate nests of prostate cancer, more than one in half those men. In Caucasians, it was lower, but still very significant. So there's no such thing as early prostate cancer, because the typical age of diagnosis of prostate cancer in men is in their 60s. Numerous autopsy studies confirm that 80% of men in their 80s have prostate cancer. Fortunately, only 2 or 3% die from it. So this means most men will die with prostate cancer, not from it. And it turns out that prostate cancer is the most over-treated disease in history. And urologists and radiation therapists have been doing a major disservice to men over the years. It's the only cancer where surgery has never been proven to prolong survival, but somehow became the gold standard. I wrote a paper many years ago that I titled The Platinum and Diamond Standard, showing that the gold standard was far inferior. And my platinum and diamond standard was 13 months of triple hormone blockade. But realize that as of 2012, when the National Cancer Institute study was published and showed that surgery was no better than observation, it's hardly surprising that my triple hormone blockade was at least as good as no treatment. So when a patient develops a relapse, recurrence, many years or even decades after his initial diagnosis, where did the recurrent cancer cells originate? Because, for example, if a prostate cancer or breast cancer patient develops low back pain, let's say 7 years after their initial diagnosis and treatment, and a bone scan is obtained, and the bone scan is abnormal, it shows multiple hot spots that were not present before. They don't have bone cancer. They have prostate cancer cells in their bones or breast cancer cells in their bones. And any medicine that can kill prostate cancer cells in one part of the body can kill them in another part of the body. Now I say can because there are places in the body where the percentage of response is higher than in other places. For example, medicines kill prostate cancer cells most effectively in the prostate. Cells that escape the prostate are much more aggressive. They have figured out a way to get out of the prostate, enter the circulation, spread through the blood, not get killed by the immune system. Find a way to get out of the circulation because, veins return blood to the heart, pumps it to the lungs, returns it back to the heart, and those cancer cells, meanwhile, are hitching a ride. And then from the heart and the left side of the heart, the blood gets pumped to all parts of the body, including the bones. And the cells, those cancer cells now have to figure out, how can I get out of this blood system and settle into the bones. Once in the bones, any cancer cell cannot grow larger than 2 millimeters unless it attracts its own blood supply. And that is called angiogenesis, bringing blood supply and nutrients and oxygen to the island of cancer cells. This is why part of our therapy for high-risk disease is anti-angiogenic cocktail, drugs that turn off the blood supply to cancer. Research has shown cancer cells circulating in the blood have a half-life of only 2 or 3 hours. That means if 100 cells get in the blood and cancer cells, 3 hours later, you take a sample, there's only 50 of the original. 2 hours after that, there's only 25. So if there's circulating cancer cells 2 decades after a mastectomy, and there's no evidence of an expanding population of cancer cells, where'd they come from? And the same phenomenon in prostate cancer cells in lymphoma patients. Dr. Judah Folkman, who was the father of angiogenesis, and in my opinion, who richly deserves the Nobel Prize in Medicine, hopefully that will come soon, is the doctor who first discovered the mechanism of angiogenesis, pro and anti. And he found that the cancer cells are not dormant, hiding. They're not dormant. Instead, there is a balance between accelerated replication, production, and accelerated death, which is called apoptosis. So these cancer cells, 20 years after a mastectomy, are not sleeping. They're constantly growing. But some mechanism in the body, anti-angiogenesis, is killing them as fast as they're growing. Dr. Folkman described what he called the angiogenic switch. Something changes, and that balance is shifted, leading to the expansion of the cancer cell population and the appearance of metastatic disease. There are a multitude of factors that could cause this. Perhaps environmental, smoking, asbestos exposure, radiation fallout. These are the obvious ones. The equilibrium has ceased to exist. The pro-angiogenic, the bad guys that wants to bring blood to the cancer cells, are now greater than the anti-angiogenic factors, thus triggering this switch. The body may have been producing anti-angiogenic factors or tumor suppressor proteins, but something has caused this to stop or to slow down. If you no longer produce inhibitors, then the bad guys grow. What I have been describing is not just a theory. To be sure, there are many pro- and anti-angiogenic factors that remain to be identified. But this should help you to understand why metastatic prostate cancer or metastatic breast cancer are considered incurable diseases. Highly treatable. They are compatible with a normal lifespan, but are not considered curable at this time. So the realistic goal of treatment is to convert it into a chronic disease that you can live with and die with, not from. You cannot cure diabetes or hypertension, almost never anyway. But by taking some medicine every day, you can control it. You can turn it into a chronic illness that you live with. Just like you can do with prostate cancer. A article appeared in Wall Street Journal 2005. Researchers reported study of just under 1,200 breast cancer patients concluded that operating and removing breast cancer cells triggers the release of certain growth factors that stimulate dormant cancer cells to undergo angiogenesis, start growing, which then results in the appearance of islands of metastatic breast cancer cells in distant sites such as bone, lung, liver. Now, remember a very famous old wives' tale, and my grandmother would tell it to me. She'd say, "Babala." I said, yeah, Bobby, tell me. She said, you know, when you cut into cancer and expose it to the air, it's going to spread. And I'm not going to criticize my grandmother. She made the best matzo ball soup. But it isn't exposure to the air. Here is an explanation for it. And then I came up with, how does the wound know to close after, for example, a mastectomy or a radical prostatectomy? Well, the body develops growth factors. So basic fibroblast growth factor, platelet-derived growth factor, et cetera, et cetera. These factors bring normal tissue together, but those factors can preferentially stimulate cancer cells to grow. So Bubby was right about the process being harmful to the person, but it wasn't the air. Now, Dr. Folkman, who unfortunately died just a few years ago, was a pediatric oncologic surgeon at Harvard's Boston Children's Hospital. And I remember when I worked with him, and we were looking in a two-headed microscope, and he said, "Bob, the secret to controlling cancer is turning off its blood supply." Now, I have a very logical brain which has no abstract ability to think. And like in high school, for when we had our IQ test, I did well. We had mechanical aptitude. At the time, 15 or 20% of the city of Chicago's high school students were illiterate. In spite of that, I found myself ranked in the lowest 3% for mechanical aptitude. I knew how to read, lowest 3%. So when he said that to me, I'm picturing he goes in and operates and ties arteries and veins off so there's no blood supply. But of course, he's thinking of these angiogenic factors. I was blessed and honored to spend part of my hematology oncology fellowship working with Dr. Folkman, because I think it allowed me to consider myself an expert, and Dr. Asagian also I know is an expert. The definition, of course, is a fast-talking SOB from out of town. Based on how long it took us to get here tonight, we qualify. Okay. Patients with metastatic androgen-dependent prostate cancer, no prior exposure to hormone blockade. Historically, these men were treated with hormone blockade alone, and despite initial responses in over 90% of them, virtually all men progress to what was called hormone refractory prostate cancer. We now know castrate-resistant prostate cancer, after an average of only 18 to 20 months. And it depends upon the number of metastases, the number of spots you see on a bone scan. If there are more than 20, the average response is closer to 12 months. If there are fewer than 5, the average length of response is over 5 years. Now, once you develop castrate-resistant prostate cancer, if the first time you're on hormone blockade, your PSA goes down, after a period of time it starts to rise. That's castrate-resistant disease. But you can be treated with a second hormone blockade agent, and if your PSA drops, it shows you really weren't castrate refractory, you could still respond. So that's why the name changed to castrate resistant. But the average survival for metastatic castrate-resistant disease has been about 2 or 3 years with traditional therapy. In the past 2 years, especially with the release of abiraterone and Xtandi, the average survival has improved to 3 to 4 years, depending on extent of diagnosis and prior therapy. If you had metastatic castrate-resistant prostate cancer, would you believe 3 to 4 years is enough for you? Hardly. And this is where we started to develop our approach. Beginning in 1997, I recommended that my patients reject the usual treatment options that were offered. Instead, we pioneered our own unique, highly successful treatment protocol, individualized. Not only is it individualized day one, but every time you come in for treatment, we review everything and see what adjustments, if any, need to be made. Our treatment is constantly evolving to improve efficacy and/or reduce toxicity. Now, treatment options for castrate-resistant prostate cancer. Most so-called experts advise using sequential endocrine therapies. For example, if you've been on Casodex, maybe they'll recommend flutamide. Then they'd recommend nilutamide, and so on down the line. Some advocate a second, even a third anti-androgen after progressing on prior anti-androgens. This was something that I was the first to do. When Casodex got approved, it was approved as a 50 milligram dose. I was a Casodex investigator. And what we found is men who progressed on 1 Casodex a day, if they were then, their PSAs go down initially, then they rise. If you then gave them 3 a day instead of 1 a day, about a third of the time PSAs went down again. So it was, to me, a pretty simple concept. Why would you treat someone with 1 a day to begin with when you know it's not as effective as 3 a day? That's how I came up with 3 Casodex a day all at one time as part of my triple hormone blockade. Although it seems that there are numerous secondary hormone blockade treatment options for patients with castrate-resistant prostate cancer, none has been found to prolong life. Average response rate 35%, duration of response 3 to 4 months. As I mentioned a little bit ago, abiraterone and Xtandi are the first exceptions to this, but they are not anti-androgens per se. They're in a separate category of drug. So that's why I put it on this slide. Initially, anti-androgens bind to the androgen receptor on prostate cancer cells. And what I describe it as, imagine the androgen receptor on a prostate cancer cell is a lock, and the Casodex is a key. Casodex key fits in the lock, turns the lock to the right, and it kills the prostate cancer cell. Now, over time, there are mutations that occur. The lock changes. And now when Casodex fits in the lock, it turns it to the left, and it stimulates prostate cancer cells to grow. So over time, these mutations develop, and instead of killing the prostate cancer cell, stimulates it to grow. This is why I refer to this as the Benedict-Arnold syndrome. And those of you who took American history know that in the French-American War, Benedict Arnold was a great general, won many battles for us. But then in the Revolutionary War, he didn't turn neutral, he turned traitor. That's what Casodex and the other anti-androgens do. We believe that you should not use an antiandrogen more than once on a patient, even if the last time they were on Casodex, they responded. The reason for that is eventually they develop these mutations, and the Benedict Arnold and the antiandrogen stimulates prostate cancer to grow. And if at the time that happens, they are on other elements of our three-pronged approach, which lower the PSA, you won't be able to identify when Benedict Arnold arrives on the scene. The PSA will still be going down, but Benedict Arnold is in the building. Therefore, if your PSA ever rises on Casodex, flutamide, or nilutamide, when testosterone is in the castrate range, we feel it is usually contraindicated to ever take those medicines again. In the past, I said always, but there are certain events, certain times that we've seen after three-pronged approach that there might be a place for some of these, although it is extraordinarily uncommon. Okay? Now, this is very important. This is some of the most important information that I have to give you. Every month that a patient with metastatic prostate cancer remains on hormone blockade brings him 1 month closer to castrate-resistant prostate cancer and thus shortens his lifespan. Think about it. We know that if you're on hormone blockade, eventually, just about every man develops castrate-resistant disease. And when that happens, your lifespan becomes shortened. In my opinion, the first time. That's for the first time. But every month that a person with metastatic prostate cancer survives and has a normal to high testosterone level, then it's an extra month of excellent quality of life added to his lifespan. He's not subtracting, he's adding, because he's not a month closer to castrate-resistant or refractory disease. And you cannot develop castrate-resistant prostate cancer unless someone puts you back on hormone blockade. If you're off hormone blockade for a while and you don't go back on it and you have a normal to high testosterone, you're not going to develop castrate-resistant disease. Castrate-resistant disease, by definition, is a rising PSA with a castrate level of testosterone. Remember, you cannot develop hormone-refractory prostate cancer unless someone puts you back on hormone blockade, and in my opinion, this is a gigantic key. The longer you are off hormone blockade, the much longer you will live. This is a major, major, major statement that I have not heard anyone else make. Now, what is the worst way to treat a man with hormone blockade? Worst way, continuous androgen blockade. The second worst way, intermittent androgen blockade. Now, you've all been told it's the best way. But that's not true. If you look at any intermittent androgen blockade series, what you find is every cycle that you are treated with, your time on hormone blockade lengthens, your time off hormone blockade shortens, and the lowest PSA that you obtain when you're being treated rises each cycle. That is hormone resistance evolving. So what is the best way? The best way is use your best hormone blockade up front, and then find a way to postpone or prevent the need to go back on hormone blockade. Now, there was an international study of intermittent hormone blockade for treating cancer of the prostate, ISICAP. And it was held the year before this in England and in 2006 in Vancouver, Canada. And this is us, 207 patients out of total of 1,700 from all these other series. And the number of patients who developed hormone resistance, we had 1 out of 207. And the median pretreatment PSA, ours was 11. There were some that were 8, and higher. All of our patients were previously untreated with hormone blockade. Because if they were treated with hormone blockade, we wouldn't treat them with that anti-androgen. Now, none of our patients had known metastatic disease. If you look at the average time on study for our patients was 1,605 days. This one was 1,300, 900, 2,000, 1,400, 1,714, 550. So our study was pretty long compared to the others. And the average time off hormone blockade, they're on blockade, they're off, it's intermittent. Average time off hormone blockade, 42%, 49, 51, 55, 48, 71, 73, 50, 56. The reason ours is blank is because it's 100% of the time. They stopped hormone blockade, no one had to be restarted on treatment. Average time to death, we had 1 death. So total percentage died, 0.48%. This was 7%, 3, 4, 17, 10, 16, 43%, 26%, 23, 31. Our results far and away the best of any published series in the world. And this was a conclusion, a summary. 207 patients, that's our group, were treated, they called it combined androgen blockade plus finasteride. You know, I named it triple blockade, but this is how they decided to write it up for their series. 97% of patients treated with this were off triple androgen blockade for over 2 years following an initial treatment period of 13 months, he put 12, compared with 29% treated with intermittent maximum androgen blockade, which is double. 97% of our patients off therapy, whereas everyone else's only had 29% off therapy. Only 1% in our group, compared to 7% of the others, developed castrate-resistant disease. 99% of our patients were alive at 5 years, compared to 89% after maximum androgen blockade. We were the first to use triple hormone blockade, the first to use finasteride maintenance therapy, and had the best result of anyone in the world. In my opinion, your survival, long-term survival, does not become threatened unless or until you developed a rising PSA while on hormone blockade. That's castrate-resistant disease. If we can find ways to postpone, or even better, prevent the need to go back on hormone blockade, then our treatment is prolonging your lifespan. That's my opinion. Once again, because what I just said hasn't been proven, although we'll show some results that are far superior to anything published. You know, the nice thing is I trained at Harvard, so when someone criticizes me and well, where did you train? Like thinking I'm going to say, oh, it's some podunk university. So it's always nice to flash that back at them. Okay, what we all came for, some of us further than others, three-pronged therapy. Okay? For patients who present with high risk but previously untreated, now these are the different categories of patients that we recommend three-pronged for. And three-pronged, you'll see there are variations in it because everything is individualized. So high risk but previously untreated, 13 months triple hormone blockade, which consists of an LHRH agonist like Lupron, Zoladex, etc. 3 Casodex a day all at one time, Proscar and or Avodart, then Proscar and or Avodart maintenance. In addition, 12 doses of weekly low-dose Taxotere, MCIT, carboplatinum chemotherapy, 3 weeks on, 1 week off. What this means is if you were on this and you were getting your first dose of chemotherapy Friday, then you get 3 Fridays in a row, you get an intravenous medicine. The 4th Friday, you're off. Then you start again, 3 Fridays in a row and off. Total of 12 doses, not 12 4-week cycles. 12 days only. And we have never had a man throw up from this. Never. Only about 1 in 7 get significant hair loss, which is always reversible. And anti-angiogenic cocktail, but because these patients have the best prognosis of men that we put on three-pronged, the anti-angiogenic cocktail is used depending on how high their high risk is. And that consists of leucine, which is an injectable medicine that you give yourself, a daily pill of either Revlimid or thalidomide, anticoagulation because there is a significant risk of blood clots developing if you don't take anticoagulation. This is administered at home by yourself, little tiny insulin needle in the belly, then the needle is short, you can't hurt anything. You or significant other can be taught how to give it. Then there are some supportive medicines which we'll talk about. And at the end, there's the option of high-dose testosterone if desired. For anti-angiogenic cocktail, leucine and Revlimid and thalidomide are not chemotherapy. They're not hormone blockade. And they stimulate and enhance your immune system. Isn't this exactly what you've been looking for? Medicines that's not chemotherapy, not hormone blockade, and improve your immune system and kill prostate cancer. These medicines control PSA and can postpone or prevent the need to go back on hormone blockade, which means you can't get castrate resistant. For patients who had prior hormone blockade, they get 9 months of an alternate 3-drug hormone blockade treatment rather than triple 15 doses of TEC, not 12. But remember, we've gone from 13 months hormone blockade down to 9 because they've already had some hormone blockade, and we don't want to risk that castrate resistance. They definitely need anti-angiogenic cocktail. They also need those miscellaneous drugs we haven't talked about yet. And at the end, we consider high-dose testosterone. If they've had prior radical prostatectomy or radiation, or if they have castrate-resistant disease, then these are the different approaches. And I think the details are not important. We've named this three-pronged approach. And a way to look at it is imagine that you are at war with prostate cancer cells. And fortunately, you have your own incredibly powerful military force at your disposal. It consists of Army, Navy, Air Force. Okay? Now, some prostate cancer experts advise their patients to always keep some of their powder dry. Save some ammunition for a rainy day. In this scenario, you would first send in your army to fight the enemy, the prostate cancer cells. They'd put up a good fight, but over time, the PC cells would mutate and develop resistance. And that would be relapse. The disease comes back. You then turn your Navy loose. Momentum shifts back to you, back in remission. But the enemy, once again, will be doing everything it can to mutate and develop resistance to the Navy's meds. Disease progresses. Okay, well, then you'd go on to Air Force, same thing. We believe that by attacking the enemy with all 3 branches of your military, you achieve the best results. Our own patient outcomes are far superior to any published results. You can call our office, request a copy of our patient volunteer list. men that have volunteered to talk to other men who are thinking about being treated or just want to talk about prostate cancer therapy or just shoot the bull. Castrate-resistant prostate cancer patients face a major challenge attempting to extend their survival. Continuous chemotherapy until progression or unacceptable toxicity has been the gold standard up till now. We don't do it that way. Tomas Beer reported on 250 patients in 2008 that were able to stop their chemotherapy, Taxotere, 18%, for an average of 18 weeks. But follow-up suggested that they didn't survive as long as men who stayed on chemotherapy continuously. In our practice, over 90% of our patients are able to stop chemotherapy, usually for many years. And to date, if a man has been off chemotherapy for at least 9 months, there's almost 100% likelihood they would respond to another cycle of chemotherapy. The hardest thing for a prostate cancer patient to accept emotionally, psychologically, is that when prostate cancer has metastasized to distant sites, such as bone, it's not a curable disease. We wish that it were. Maybe in the future it will be. But recognizing that your disease is not curable is only difficult as a concept to accept, because ordinarily when you hear someone has incurable cancer, you think of someone only living a few months or maybe a year or two. But fortunately, almost without exception, our patients will live much, much longer, assuming that we treat them and they actually take their medicines. For men with metastatic prostate cancer, our goal is to control it, turn it into a chronic illness you live with, die with, not from, but it does require therapy. Now, we finally get to some wonderful stuff about testosterone. Testosterone has been considered contraindicated for men with prostate cancer. Everyone knows if taking testosterone, if you have prostate cancer, it's like pouring gasoline on a fire. How do you know that? Well, Nobel Prize in Medicine was awarded to a guy at University of Chicago, to two guys that found that when you do orchiectomy on men with metastatic prostate cancer, 80% of them have a dramatic response and improvement. But within 18 months, their prostate cancer comes back with a vengeance, even though they don't have testosterone. So something doesn't add up there. There's no doubt that established prostate cancer is stimulated by androgens. No doubt, said this guy. Didn't cite any references. So there you go with that own wrong opinion stuff. Okay? Don't believe opinions. The louder the opinion, the less the facts. There were 2 articles that were written by Fowler and Whitmore, and these are the articles that are quoted as saying that testosterone is contraindicated. However, the 2 articles involved the same group of men. There was a retrospective analysis where they went back 10 or 11 years and reviewed charts that didn't have dictated notes. They didn't interview patients, and they made conclusions. Now, from that same article, they noted that 7 patients that were given testosterone had improvement from 50 to 310 days, actually one of them 420 days. And there were 3 groups of patients, and there were 18 patients in 2 groups. 7 out of 18 improved when they got testosterone. And they concluded response of patients with metastatic prostate cancer to testosterone has not been evaluated systematically in a large number of patients. But this is the article that everyone says proves that you can't use it. The authors from this article noted the paradoxical ability of testosterone to induce symptomatically beneficial responses, and mentioned that others have described similar experiences in patients with metastatic prostate cancer, meaning benefit from testosterone. So here's a doctor who had 10 patients who were untreated or recently castrated. Most of the patients, when treated with testosterone, had an improvement in sense of well-being and some decrease in pain. Another author, 52-year-old man, severe low back pain, prostate cancer, locally advanced bone metastases, castration, estrogen for 3 months, low back pain recurred, required narcotics, given testosterone, pain worsened for 4 days. On the 5th day, pain disappeared. He was supposed to get radioactive phosphorus, never got it, pain-free for 9 months. And his acid phosphatase normalized. This is like a pre-PSA blood test. And despite decades of research, there's no compelling evidence that testosterone has a causative role in prostate cancer. New England Journal of Medicine. Men with higher levels of testosterone are not at increased risk for developing prostate cancer. And as a man ages, testosterone declines. What about the risk for getting prostate cancer? Goes up with aging as testosterone goes down. When failure is manifest under estrogen suppression, in other words, this is in days when estrogen was a major treatment for metastatic prostate cancer. Reversal to the opposite extreme of male hormone, female hormone balance should be instituted and observe its effect. Now, this article was published in 1947. When I rediscovered this, it blew me away. So maybe there's more. 3 patients, advanced prostate cancer, prognosis is hopeless. They were chosen for a study, treated with testosterone. 2 of the 3 symptomatically improved within 2 weeks. 1 had a palpable reduction in the size of the prostate. This was written in Archives of Surgery, 1950. Improvement lasted 5 months, at which time symptoms recurred, got a second course of testosterone, again improved. 3rd person got worse for the first week, then returned to baseline. And it seems to us that if continued progress is to be made in the treatment of prostate cancer, the exact role of androgens in the induction of cancer or maintenance of cancer growth must be ascertained. 1950. 76-year-old, severe back pain, weakness, lost 89 pounds in weight. He had been castrated in estrogen, not able to sit without assistance, appeared terminal, extensive bone mets, enlarged nodes, prostatic acid phosphatase 50 times normal, started on testosterone. 1 month later, pain-free. Excellent appetite, ambulatory on his own, 112 pounds, acid phos drop. He gained 30 pounds, was able to stay on testosterone just about a year. Testosterone alone may therefore be indicated in cases of relapsing prostate cancer unresponsive to estrogen. Now, can hormone blockade cure prostate cancer? No. But I've been recommending triple hormone blockade instead of surgery or radiation since 1991. And it can't cure prostate cancer. So we had a patient, December of 95, was 52, Gleason 6, reviewed at Johns Hopkins, PSA 7. He was treated elsewhere for 5 months with 2-drug hormone blockade, came to see me, got 9 months of triple blockade, then Proscar alone. In July '03, he started on high-dose testosterone, later added in some anti-androgenic cocktail. And these are his testosterone levels, 1,500, 2,100, 1,000, 3,678. Notice his PSA, 8, 5, 7, 5, 8, 7. 1540, 2600, PSA 7, 2237, PSA 6.4, 1200, 2100, 1400, 1422, 2031, 2791, PSA less than 7. 1863, PSA less than 7. That was in June '06. 11 years after diagnosis of prostate cancer, no local treatment, 1 cycle hormone blockade, 3 years of high-dose testosterone. Unfortunately, he was found dead in his apartment by his sister. And I wanted an autopsy. You don't know, but if you request an autopsy now as a physician, they say, who's going to pay? And I had to pay. So they did an autopsy, and I spoke to the pathologist beforehand. He knew the history, so he not only made tiny slices through the entire prostate, but he sectioned the spine lengthwise, because he knows that's where prostate cancer spreads most commonly. And he made slides from every part of the spine. In this case, this person was found to have 90 and 85% block of 2 coronary arteries, resulting in reduced oxygenated blood flowing to his heart muscle, and this, in addition to his hypertension, placed him at greater risk, sudden irreversible cardiac arrhythmia or heart attack. So he was diagnosed with prostate cancer in 1996. He's been under therapy. At autopsy, there is no evidence of recurrent or residual prostate cancer. Prostate gland demonstrates benign findings, no evidence of cancer. No evidence of cancer anywhere in his body, including 3 years of high-dose testosterone. How's that? Okay. Now, this is a patient that came to me from Germany, December '98. 62-year-old engineer, and he's one of more than 150 patients we've consulted on from Germany alone. He had a T3A disease and a PSA 39. Gleason 7, 4 out of 8 cores were involved 100%, and these were per review of Johns Hopkins. He had 2 months combined hormone blockade, then 12 months triple blockade through February 2000. And his PSA rose. I started him initially on thalidomide, later added in leucine, which is part of the cocktail. And he used to, being an engineer, you know, he'd graph his PSAs, do logarithmic graphs. He loved it, all this stuff. Isn't that beautiful? This PSA now is down to about 2 or 3, and it had been 15. Not from another cycle of hormone blockade, never having had chemotherapy, just the 1 hormone blockade cycle and anti-androgenic cocktail. Then this is a PSA of 15. He added all the different things that he was treated with, as of 2008, his PSA was 2.33. Then this was when we started another cocktail agent, interferon. Revlimid was added here. This is June of 2009, PSA about 2. Then his PSA began to rise, and in November of 10, he started on, received chemotherapy and hormone blockade cycle number 2. His PSA dropped to as low as 0.03. He was off treatment, and PSA rose to 5.73. He went on Zytiga alone. PSA dropped to about 1, and his testosterone was less than 20. We started him on testosterone replacement therapy in March of 13. His PSA initially increased to 17. Scary, right? So we continued it. PSA dropped to 15, and this month is 13. And he feels better than he's felt in 20 years. This is a gentleman who presented at age 61, PSA 3,346. Anyone thought they had a high PSA? All right. He was a patient at Kaiser, urologist that made the diagnosis, multiple bone mets, told him that he needs to go on hospice. He had metastases in bilateral ribs, thoracic spine, lumbar spine, pelvis, femurs, left shoulder blade, the junction between the chest and the neck, 22-pound weight loss, severe bone pain, urinating every 20 minutes, told to get his affairs in order, that he would not survive more than a few months. Came to see us December 03, 13 months triple hormone blockade, Taxotere MCIT carboplatinum, 15 doses through April 04. PSA dropped to unmeasurable, 0.003. Added anti-androgenic cocktail. January 05, stopped hormone blockade, continued cocktail, added high-dose testosterone. Testosterone 1600, 3700, PSA 0.37, 5400, PSA 0.45, 3500, 0.36. You get the idea here. And in January of 08, PSA 1.8, 2.1, 2.34, 2177 testosterone, July 08. So he went off testosterone, and when he did, PSA became unmeasurable in March 09. So started with 3300 PSA, took high-dose testosterone for 3 years, unmeasurable PSA. When we did a Duke Bond study, transrectal color Doppler study, no evidence of cancer in his prostate gland, 0. It had been over 5.5 years since he presented with PSA 3346 and was referred to hospice. He's back to work full-time with no symptoms and no pain. If this does not impress you, nothing I can say is going to help. This was one of my favorite patients. His son and my son were classmates at Harvard MBA. 81 years old, 30-pound weight loss, horrible bone pain, bedridden, admitted to the hospital at the time of his bone scan because of severe pain. He had to require shots of Demerol just to get the scan. PSA 6,272. He required a morphine patch, narcotic pills, and a wheelchair to come out and see us. He got 12 doses of chemotherapy, 13 months hormone blockade. PSA dropped to 18, a little later to 1.35, which is a decline 99.978%. And he got some high-dose testosterone, and for his 85th birthday, his family took him out to dinner, and on his next office visit, he showed us his birthday pictures from Hooters. He had never been to Hooters. Had another cycle of hormone blockade, started another cycle of testosterone, and died of Alzheimer's in January 05. This is also one of our favorite patients, a physician. In 1989, 59, PSA 134, Gleason 7. He took a couple of months hormone blockade, had a radical prostatectomy, came to see me in May of 99, PSA 12. No prostate, PSA 12, he's got to have disease. Had a new young wife, and she did not want him on hormone blockades. They both wanted to be sexually active. So I put him on some anti-androgenic cocktail, and his PSA was 7 3 years later. And he wanted to start on testosterone. His PSA was about 7. His PSA went up to 15. Notice as his testosterone went up, his PSA began to level off. And when he came to us, his PSA was 12. Here's 12.9. Now, testosterone 2300, PSA 14. And just nice, stable PSAs. We added in leukine, and in April 09, PSA was 10. Been 24 years since he presented with a PSA 134. PSA began to rise a year and a half after a prostatectomy, and 14 years after consulting with us. PSA in the 10 to 12 range, and testosterone in the 1,000 to 2,000 range. The past 14 years, no hormone blockade, no chemotherapy. And he continues to work as a physician.
As I mentioned in the beginning, when I came over, Dr. Bob would tell me these stories, and I would say, no, it can't be. How could somebody have progressive prostate cancer and you put them on testosterone? And there's not a day that I don't call him and I'll tell him, you know, I saw Mr. H. He came in, he's been on testosterone for 12 years, and his, you know, PSA bumped up a little bit, but, you know, we don't get nervous. We just, you know, check it again in a month, and it comes down. And again, these are just Dr. Bob's favorite patients. I always try to add, you know, new patients from our, you know, current clinic, but, you know, these are the ones that really stand out. But these are not, you know, cherry-picked patients. Most of the patients who actually go on therapy tend to do well and have, you know, great lives. And I've never heard such dirty sex stories from, you know, 70, 80-year-old men who come to our clinic. So in the beginning, I just thought it was a little bit odd, but now it's just really become part of the routine. So, you know, Dr. Bob has always been ahead of his time. And then when I came over for my training at UCLA, we've been trying to incorporate more of the newer technologies into the practice. So I literally only take a few minutes, and I just want to make sure that you guys have heard of these technologies, because it does make a big difference whether you're going to be treated, you know, as local disease or metastatic disease, and how, you know, we would offer you different therapies based on, you know, upcoming therapies and not just sticking to old therapies that have been around for a long time. So anybody who's been to our clinic knows that the CTC machine, the circulating tumor cells, is part of our daily practice. And again, I won't go into detail, but it's a blood test that's FDA approved, it's covered by Medicare, and it's actually a very sensitive way to test if there is circulating tumor cells in your body. So we use this on a very routine basis, and it's very helpful in determining whether we stop a therapy such as testosterone or not, because a lot of times the PSA might not respond, but if you see circulating tumor cells, then, you know, you would change therapy. The next few slides, again, I just want to make sure you guys have heard of it. These are the newest technologies in detecting metastatic disease. So if your doctor ever recommends a conventional bone scan, maybe next time you'll, you know, mention the F18 bone scan. It's a bone scan that utilizes PET technology. It's FDA approved, and again, everything we do is covered by Medicare, so they should cover it. The next one is the choline C11 PET scan. So instead of doing a conventional PET scan, you can ask for this. The F18 bone scan is covered and available throughout Southern California. This one, it's still not yet available, but we have patients that go to Arizona and Mayo. And again, as long as your doctor knows about it, they can refer you to the right facility. Now, you guys asked about this. So novel therapies, again, so many drugs coming out this year. There'll be another 2 that come out, and next year there'll be another 2. So again, you just want to have this conversation with your doctor. So one is Provenge, and again, you guys have all heard about Provenge. It was based on the IMPACT trial, approved in 2010. Again, in our clinic, we tend to use it, but not as much as other people, and part of it is because, again, we tend to see higher risk patients, and as you can see, the benefit is not that significant. It's only indicated if it's asymptomatic disease, and again, it's a very expensive medication. It costs about $90,000, and again, it's hard to convince somebody of, you know, very little benefit if they have such advanced disease. But again, we do use it if needed. Next one is Jeftana. Again, you guys might have heard about it. It's a chemotherapy for post-Taxotere. The main point is that it has a lot of side effects. So again, that's why ever since I've been there, I've actually been very impressed with the weekly TEC compared to Jeftana. Next one is Zytiga, and then MDV 3100 Xtandi, which we use a lot in our clinic. These are the 2 new novel agents that have been FDA approved. And then this one, again, I'm surprised a lot of patients that I see with prostate cancer, they're still getting Zometa, but for actually prostate cancer, denosumab Xgeva has been out, and it actually causes less ONJ and less damaging to the kidneys, and again, it's FDA approved. And Firmagon is the one that actually blows my mind, that most people are still getting Lupron instead of Firmagon, because there have been a lot of studies, and it's been approved since 2008, that have shown that Firmagon is actually leads to more rapid and sustained suppression. It doesn't cause a flare, and again, it has less bone loss and duration of response. The only downfall is that it's a monthly dosing compared to Lupron, which, you know, you can get on longer duration. But again, if it's your survival, you know, you want to do it. Anyways, these are just some slides. Will be available. These are all on all the newer therapies. I'll let you guys look at it, but I'll give you guys One small story about our clinic, and I just saw this guy yesterday, so I put him on our slide set. XL 184, I don't know if you guys have heard about it. It's the new drug that's going to be approved in prostate cancer. And we were actually in our clinic able to get it for him on compassionate use. So again, like Dr. Bob said, every treatment is individualized. We go out of our way to get drugs approved for our patients. And I just want to show you guys his response, and then we'll end with that. XL184 is a novel agent. This is going to be the next drug probably approved after Zytiga and Xtandi. And again, there's a lot of phase 2 data, but the drug is not yet available. There's 2 phase 3 clinical trials, COMET-1 and COMET-2, that are underway. So we had this patient came to our clinic. He's progressed on everything. I could have offered him hospice, but instead we went out of our way and we got him this drug off-label. And the point is to never give up. And this is his history. When I saw him, he had failed everything. And this was about a month ago. PSA was 46, CTC was 408. And within a month, I just saw him yesterday, his PSA has come down. And again, another example why the CTC is much more important, it's come down to 25, and he has decreasing bone pain, and he feels great. So the point of it is just never give up, and always have your doctor be your advocate, and not somebody who just wants to put you on a clinical trial or advance their own career instead of wanting to advance your life.
One of our supportive drugs that we believe helps prostate cancer are statins. And a study in 2008 found that for every 10% decrease in LDL cholesterol after starting a statin, the PSA declined by 1.64. For men with the best LDL declines, over 40% after starting a statin, PSA declines of 15 to 24% were found. Now, there are 2 major forms of cholesterol, HDL and LDL. A lot of people have trouble remembering which is good, which is bad. And here's a pearl so you'll never forget it. HDL begins with an H, so you want it to be high. The higher the HDL, the better the prognosis. Higher the HDL, lower the risk of heart attack or stroke. LDL begins with an L, therefore you want it to be low. Now, what they sometimes call normal LDL, some call it 130, some call it 100. However, if you've had a cardiovascular event, you need to get your LDL down to 60 or 70. Why wait for the first heart attack or stroke to get your LDL down to 60 or 70? Just another little pearl, if you happen to have an infection anywhere in your body, it can falsely elevate your PSA. A doctor that I respected a great deal was famous for managing non-Hodgkin's lymphoma and Hodgkin's disease, said, pick one disease, study it well, and it will carry you to the ends of the earth. And when I went to London to lecture, when I lectured in Canada, or when I lectured in Germany, I said, this maybe is what he means by the ends of the earth, but I think what it is that it gets you in contact with patients and with other researchers that are experts in the one disease, and permits you to know that you're doing everything in your power to help one patient at a time do best. And do not follow where the path may lead. Go instead where there is no path and leave a trail. Discovery consists of seeing what everybody has seen, namely testosterone and prostate cancer, and thinking what nobody has thought. Except I only copied or rediscovered what people found in the 40s and 50s. The significant problems we face cannot be solved at the same level of thinking we were at when the problem was first recognized, relationship of testosterone and prostate cancer. We had 2 others, was be happy, be well, live long and prosper, and I wanted to thank Joanna for her assistance and doing all these slides, and the rest of our compassionate oncology staff for treating our patients. Thank you.